evidence-based practice in home health physical therapy. My name is Michelle Vanderhoff, and I'm the staff editor for the American Physical Therapy Association's PTNow blog. To start the discussion, I'd like to introduce Mary Blackington, our moderator tonight. Mary is a physical therapist, associate professor, and associate director of the hybrid entry-level doctor physical therapy program at Nova Southeastern University in Tampa, Florida. Mary, welcome.
Thank you, Michelle. And we are so excited tonight to be talking about knowledge translation. And to do so, we have two very impressive guests joining us today. The first is Patty Sheets. Patty is Director of Quality and Clinical Outcomes at Infinity Rehab, a skilled nursing rehab provider now in 9 states. Previously, she was a national clinical specialist with Gentiva Health Services, a national home health and hospice provider. Patty is Vice President of APTA's Neurology Section. In the past, she's served on the American Board of Physical Therapy Specialties Neurology Specialty Council and as chair of the Neurology Section's Stroke Special Interest Group. Welcome, Patty.
Thanks.
We also have with us tonight Ken Miller. Ken is Clinical Director for Catholic Home Care and a guest lecturer and adjunct teaching assistant in the DPT program at Touro College in Bayshore, New York. He is a member of the editorial boards of Jerry Notes and the Journal of Novel Physiotherapy and Physical Medicine, and he's also a reviewer for the Journal of Geriatric Physical Therapy. As chair of the APTA Home Health Section's Practice Committee, Ken has led to the development of a new handbook providing physical therapy in the home, as well as the Home Health Student Program Roadmap and Toolkit, and finally, the Home Health Section's Toolbox of Standardized Tests and Measures. Welcome to the Hangout, Ken.
Thank you very much. It's nice to be here.
Wonderful. Well, we really appreciate you being here, and a note to our viewers, if this is your first time of watching a Google Hangout, the person speaking is usually front and center on your screen with the other participants along the bottom. Occasionally, you'll see a change of the person in the center, but that's just what happens here in the Hangout. So, without further ado, I'd like to begin, and Patty, I'm going to address my first question to you. As you know, part of the mission of PTNow is to make it easier for clinicians to use available evidence in practice. In your current role, you focus on knowledge translation for clinicians. What are some of the barriers that physical therapists face when trying to apply best practice in their physical therapist practice?
Yeah, that's a really good question, Mary. You know, I think the barriers come in all kinds of forms. One of those forms is a knowledge barrier. So it has to do with just knowing what's in the literature and being aware of what I should be doing differently in my practice compared to what I'm currently doing in my practice. And so there's been some development of synthesis types of documents, meta-analyses, or clinical practice guidelines has been a big effort that APTA has been making that would help clinicians kind of have a synthesized set of information to consider. So that's one of the barriers, is just knowing about what new evidence is available or that they should be thinking about. I think there are other barriers that have to do with skills. And so in this situation, when you think about skills, sometimes I might know what the evidence says, but I don't exactly know how to do it. So you can read about, say, task-specific practice, but then you think about, what does that really mean for what I need to do differently with my patients? Or I understand conceptually motor learning principles, but what do I really need to, how do I need to interact differently with my patients to be using those principles? Or maybe it's balance training, and we understand that, okay, I get conceptually that my balance challenges need to be maybe more challenging to the patient, but am I comfortable doing that with really asking the patient to perform tasks? Do I feel safe, and do I feel like I can keep them safe when we do that? So sometimes there's really a skill barrier in being able to do something different. And then probably as much as there are knowledge and skills barriers, there are attitudinal barriers. So, as clinicians, we really work really hard to kind of get into a groove of practice. And that actually makes us much more efficient with the way we do things. It simplifies not only the movements and the actions that we make in practice, but it simplifies our thinking as well, and so it allows us to do our jobs with increasing speed and in a lot of ways increasing effectiveness. But that can also make us kind of resistant to doing something new. And so we don't like disruptions to activities or actions that are going to cause kind of a kink in our system. We're going to know how to groove what we do every day. And so sometimes that kind of can be a barrier for us. The other thing from an attitudinal perspective is that when you've been practicing as a clinician, when you kind of have to take a look at new evidence, you really have to really kind of say, okay, that means that all these patients I've treated to this point, maybe I should have or could have done some things differently with them than I've currently been doing. And so that kind of requires some introspection and kind of, it has to be okay for us to really be able to look at our past practice and say, I did the best that I could at the time, but now I know new things, and be willing to kind of attitudinally get on board with something new and make some of those shifts. So I think those are some very really strong personal barriers that we can have, that we kind of have to work through on an individual level. And then the other piece I think that can be a real barrier is trying to figure out how to adapt some of what's in the literature to the local context. So again, so much of our science is coming from the laboratory setting where we have all types of controls. It's a selected set of patients that were studied, and we controlled the interventions, and we controlled the timing of the interventions and the amount of the intervention and all of those variables. But practice is full of things that are not controlled. So the patients that we see in practice are often the folks on the exclusion list in a study because they have mixed problems and where they have all these complications, and that's the kind of the typical patient in practice. And so there's some barriers there in trying to extrapolate what's been done in a very controlled environment to figuring out what that might mean in the local context and what can I apply from what's been learned in these more controlled settings to what I am actually doing in the care that I deliver every day. And then finally, the last set of barriers that I think is important for us to think a little bit about are some of the organizational barriers. So some of us work as independent practitioners and we just have to worry about ourselves, but many of us work in settings where we're working with other people. We have bosses and we have programs and kind of rules that govern our practice that come from the organization itself. And so thinking about, do I have support in my environment for doing something different? What are my peers doing? If I kind of all of a sudden start behaving differently, will I just kind of get kicked out of the group, if you will? So if I do apply these principles, do I have a system organizationally in which to document some of these new types of interventions? And so there can be a lot of barriers at the organizational level. So it's actually probably, when you think about some of the challenges, it's not necessarily surprising that across all areas of healthcare, we struggle to get what's in the science into practice. On the flip side of that, it's definitely worth the effort to try to overcome all of those barriers.
A lot of those barriers resonate to me, and I know at the academic level we try to address those barriers in advance. I was a little surprised that you, under organizational, would you consider time a perceived barrier by clinicians?
That's a good question, Mary. And I think, you know, every time that you disrupt the flow of a clinician's practice, it's going to take them more time to do things. And so I think that that's an easy default of, you know, I don't have time. So yeah, that's a really good. My sense is that sometimes it is a real-time barrier. Sometimes it's an attitudinal barrier, that there's a sense that I don't have time. And frequently, I think, when we think about integrating evidence, we think of it as additive. So I'm going to keep doing everything that I've been doing plus. And I actually think that to be successful in integrating some of this evidence into practice, we have to think about substitution strategies. So instead of X, Y, and Z, which I ordinarily do, I'm now going to try A, B, and C. And that, to me, at a personal level and at an organizational level, is a real key to the time barrier.
Yeah, that makes a lot of sense. And the thing I can think about, and it will date me a little bit, is when we finally realized maybe 25 or 30 years ago that betadine and other chemicals actually are cytotoxic in wound healing. And there was a huge, oh my gosh, I've been doing it wrong all these years, or, you know, do I do that plus other things? So it really resonates with me personally as a clinician. Ken, I'd like to address the next question to you. And do you feel that there are particular knowledge translation challenges in the home health setting, or are the challenges similar to what other physical therapists face?
I think the problems are very similar in most of the practice settings. I think the barriers that Patty just talked about regarding attitudinal or knowledge itself, cognitive barriers, I think that they follow along all practice settings. I do think, however, in home health, because clinicians are working in an individual, independent environment, you know, often out in the road on their own, a lot of clinicians feel that they are isolated. But with modern technology, with LMS systems, you know, HealthStream, Corridor Group, there are a whole bunch of other e-learning platforms. And my agency in particular, we do a lot of learning online. And so we offer a lot of optional CEUs for staff. So that way they feel that they are connected. And as far as getting that knowledge cognitively into an attitudinal and more of a performance into a performance function, that's where we bring them into the office. And for a few years, we've been working on objective testing, trying to get them to expand what they're doing from what they've learned in their undergraduate and graduate work, and move towards using more functional-based exams that CMS is requiring. And what we've learned was in the first couple of years of doing it, we would go over the tests, we'd have beautiful PowerPoint slides, and we would explain the tests, and we'd go over that, and then we would look back at the records, and we'd see that they weren't implementing any of the tools. And what we very quickly decided was we needed to add practical hands-on demonstration where they actually had to use their psychomotor skills and practice. And once we integrated the practice, we saw practice actually change for using these tools that required them to do more hands-on work. So that was a nice surprise to see. And so what we've done since then is every time that we're going over procedures with our staff, we're trying to incorporate not only the cognitive domain but the psychomotor domain and address their affect as well regarding any resistance to change they might have. So that's what we've been doing, and it's been successful. The other thing that we've done is at the agency that I work at, we've incorporated our nursing staff and other disciplines into an interdisciplinary model. So what we've tried to do is have the different disciplines instruct each other on how to look at things from another point of view. And we've seen that that's had a great impact on changing how they practice, because they're hearing and looking and seeing how other people are doing it, aside from this is the only way to do it. And it's had a lot of pluses, and we see better outcomes with our patients.
Wow, well, as we are more and more focused on interprofessional care, that really makes sense to me. I wonder also, have you ever used a mentoring model where, one physical therapist might go to a home with another therapist to do sort of some one-on-one mentoring? Has that worked, or have you tried it?
With my role for where I work, I have the luxury of being able to go out in the field, and with my training with vestibular therapy and rehabilitation, whenever we have a patient that comes on program with syncope and has a history of falls, that often gets triggered to me, and I may review the chart and see if this is a patient that might be appropriate, where I'll go out with the clinician, and rather than just explain to the clinician what to do or do the visit for the clinician, we do a co-visit, which my agency is on board with, because that's financial. There's financial implications to having two clinicians out at the same time, where you can only bill for one. But what we've seen is the clinicians now are able to implement what we went over in the office, and then what happens is they become the peer-to-peer trainer to the other staff on their teams, because our teams are broken up into different regions. So we have 13 therapists that became vestibular competency in triaging patients, whether it's a vestibular origin or a non-vestibular origin, and then be able to refer out when appropriate. And then on the more difficult cases, I might go out on the visit with the clinician, and then we would actually do the visit together. And that has been very fruitful, because unless the clinicians are involved in doing the work at that time with that patient, again, the knowledge is not translated to practice.
Right, and I would also think that you mentioned earlier with technology and whatnot, something like Google Hangout or something as simple as FaceTime on your phone may be a way to do a little bit of telemedicine, where if a clinician had a particular challenge applying evidence, that they may be able to, phone a friend type of thing and get another pair of eyes there. Does that sound useful?
That is a really good point. With our clinicians, we're now rolling out new phones that are so they're HIPAA compliant, so they'll be able to take video, be able to take photographs, and be able to do more telemedicine with the patients.
Wow, fantastic. Patty, I'm curious as to whether there's been any evidence about knowledge translation for physical therapists.
Yeah, it's kind of interesting, not necessarily just specific to physical therapy, but to healthcare in general. There's kind of like this whole body of science now around this whole idea about knowledge translation. Implementation science is the term that is frequently used, and many of the principles actually kind of go back to some of the science, if you will, of performance improvement. So there's a lot of overlap in those fields of study, and trying to sort through how do we take what's in the laboratory and get it in so that patients are actually receiving the benefit of what's been learned in that setting. So I think when you look at that literature, of course different types of interventions are categorized in different ways, but I think one of the things that I think is so remarkable to me is that these are termed knowledge translation interventions, which to me sends a very clear message that our understanding that this doesn't happen, practitioners don't change their behaviors consistent with what's in the evidence just by us saying, we think it's a good idea and you should do it, here's a handout. That this is really a process. And it's a process that is a very intentional process. And so when I think of just some of my own activities that I did before we've kind of come to this understanding, I'm not sure that I was always as deliberate. I kind of thought, well, if I just told folks what they ought to do differently, that they would do it differently. And actually, the science is very clear now that we need a much more intentional process to be successful. So you have to be deliberate about it. Again, it does not happen by chance. I think you have to be, as a result of that, you have to be a little bit selective. And I think sometimes that's another challenge that we face in practice, is it like we just like say, here's like, well, I just read this. This is really important, so we should be doing this, and this we should be doing this, and we should be doing this. And so we identified too many areas in which we could seek some practice change, and we don't really take any one of them far enough in the process to really lead to that change. So in the literature, they talk about educational interventions, and this is probably our easiest thing. I mean, we've been in servicing in clinical environments for forever, right? And that didactic type of experience is probably the easiest for us to put together. But again, the evidence suggests that it's probably the least effective. So some of the strategies, Ken, that you talked about, where you shared information and then you did reinforcing of learning and practice of skills, and actually a whole group of people coming together so that the peer group can reinforce the ideas. Those are all strategies for the educational piece, for just kind of building the knowledge awareness piece, that have been found in the literature to be effective. The other thing is then building local kind of clinical support tools so that your clinicians have access to easy reminders for how to do things. And you think about lab values. You know, we're now developing enough science where we kind of, when you think about, well, how do I build speed training into a patient's walking? Or if I was going to do augmented cue training, what do I do with visual cues and auditory cues? We are now getting quite a bit of detail that maybe it's hard for us to remember some of those things. So some reminders, some ways to build in those clinical support tools have also been identified in the literature as effective. The other thing is that shows up all the time is audit and feedback interventions. So, you know, again, chart reviews have been around for forever, right? But really trying to take that maybe to a more focused effort and really auditing for a very concrete set of behaviors and being very specific in how you give that feedback. So I know in a recent project that we'll talk about at CSM that we did, we kind of took the chart audit, which was kind of a narrative kind of a feedback prior, to really kind of a scoring. And it was very simple. Yes, the behavior was there, or no, it wasn't there. And we converted that to an adherence score. So we could actually kind of translate those audit results to a measurement of adherence to the behaviors that we were looking for at a clinician level. And so that little bit of tweaking to an old process made a big difference in being able to express both to the clinicians and to their peers how we were doing in kind of making that knowledge translation leap. And then informatics is a big element or a big type of intervention that's discussed in the literature to augment and to assist in knowledge translation. So kind of figuring out what kinds of reminders you can build into an electronic medical record, what kinds of reporting you can get from your record so that you can give that feedback to clinicians. This is just a whole area where folks are beginning to try to explore, how do I encourage my clinicians to document in a way that I can get data out rather than just a purely narrative form. So again, the more that I can work through some of the input processes, the more effective my reporting might be able to be on the backside, which means I can give, again, that audit and feedback to the clinicians about how we're doing. So really trying to be really much more specific about some of those details. And then they talk about organizational interventions as well. And this is where some of the things, Ken, that you talked about earlier, some of the infrastructure that you build to support these changes, that all adds to those. I think if you can think about just organizationally with a group of people that work together, trying to narrow the focus, So maybe you select one or two things that we're all going to try to get better at. That, again, allows for some of that reinforcement of learning. And then the last two elements, once you've kind of gotten over the big hurdle of everybody knows what they're supposed to do, they've developed the skills, you're trying to audit for it, then it's really monitoring the ongoing use and figuring out how to sustain it. And the literature suggests, of course, that you won't sustain the changes unless you really have made an integrated change in the individual clinician behavior. So now, whatever that piece of knowledge translation that you were trying to be successful with, it actually has to be a part of the practice behaviors, and it's now a part of their natural groove, if you will, of things. So, so that seems to be those last elements of monitoring the use and then sustaining that is really critical to that whole, what they call, knowledge to action process.
Hey, Patty, I enjoy what you're saying. I have a couple of things to just add to what you said regarding the EMR. I know a few medical records have what they call BPAs, best practice alerts. And also look with the EMR to get soft stops and hard stops in the record. So as clinicians might be doing their assessment or doing their intervention, the EMR may be there as a prompt as a reminder to say, this is what is recommended based on the literature, based on the practice, and some of those alerts can be set by the IT of the organization. And one thing that at my organization we told the clinicians, you need to be doing pre and post sets of vital signs, and I wish that I would be able to put in a hard stop to see that there were 2 sets taken in order to realize that change of behavior. Unfortunately, I'm not with our EMR, but if I were able to put in a hard stop at this point, I would create a hard stop, and then maybe after the behaviors become learned and it's now integrated into practice, make it a soft stop and say, now you can be more aware of who might not need 2 sets of vital signs. Maybe somebody that you established has no cardiac history. You did an initial set of vitals on your initial evaluation. They have no risk factors for any heart conditions. They have no history of any heart conditions. They're not compensating. That patient may not need a second set of vitals, but at least at that point, get it to where it's a clinical decision. But until that behavior is learned, putting in hard stops, soft stops, best practice alerts might be one way to integrate with the record. Another thing is, one of the common buzzwords in the last year or so is patient engagement, patient adherence versus patient compliance. And I think a lot of this also can be related to clinician adherence and clinician compliance and clinician engagement. And Team Steps, I don't know if you've heard of, AHRQ has a program called Team Steps, and really the idea of that is patient safety, and it's creating a culture of patient safety, and they have a lot of information regarding Cotter's eight levels of change to try to change organizational behavior. So this is a resource that's free and available, and I do recommend organizations to send people to this, because that's a way to change the culture of the organization by developing a shared mental model. And like you said, if I'm the only clinician doing something, I may look like the oddball out and, not really show an effective change, because over time I don't want to be the one duck in, in a bunch of geese or whatever. So I think looking for shared mental model, Team Steps is a wonderful thing to look at. I'm presenting at CSM on patient engagement, optimal outcomes. It's a session at CSM, and what we looked at was the trans-theoretical model of change. And there are many employees and clinicians that are practicing, have been doing it for many, many years, and they don't see that there's something with their practice that should change, and then may not be in that pre-contemplative state and realize there's a problem, that they've been doing something for 30 years. So incorporating social work and psychology knowledge base, I think, is really important, and that's one thing I've been looking to do. My wife is a social worker, went back a couple years ago, got her master's degree, and from reading a lot of her papers, I've learned quite a bit of psychology to incorporate in health coaching and to try to get our patients more engaged. And when I approach it with that mindset, I feel that I am realizing a greater change on the patient's behavior. And I think it needs to be done on our clinicians as well.
That's a good point.
Yeah, this is really, it's amazing. I think there's a lot of patient behavior change and therapist behavior change. It's all behavior change, really.
Right.
I would love to address this last question to the both of you. And in your opinions, what could every clinician do tomorrow to begin integrating best evidence at point of service or for knowledge translation? And I'd like you to think about your answer both in relation to the clinician, but also their managers and leaders in their healthcare organizations.
I think one thing Patty said was real important that you actually brought up, Mary, regarding time as a barrier and adding and things being additive and not taking away or substituting. And I think that's probably one of the biggest areas where a supervisor could be involved and say, I know we keep adding and changing the documentation and it seems like we're doing more and more. Let's focus on what we're intentional about removing from that assessment and removing from that intervention to allow you for time to do these new behaviors that we want to encourage. From the clinician side, one thing that whenever I lecture, I'm trying to do less and less lecturing and more coaching. I try to tell the staff, I want you to pick one thing that you've learned from today cognitively and see where you can relate that to one patient tomorrow and try to start slow and just do one specific activity. And if you're not sure where you want to start, I think PTNow is a wonderful resource because there's a lot of evidence-based practice that's been synthesized into the different CPGs and the guidelines. I do recommend going to guidelines.gov as well if they want to get more information. So that way they can, they may not have time to read primary literature and to translate it is a challenge for most. But I think if they pick one small item and try to make a smaller behavior change, and then once they see the success with that, add another item. And then when they have challenges or they feel it's not working, that's where the idea that you brought up with a peer mentor, I think would be very helpful.
Great. Patty?
Yeah, it was hard for me to think of just one. Where I think for clinicians, I can think of 3 areas that, depending upon where the team of folks that you were working with or where you were as an individual, that you might want to think about. So one is, when it comes to assessment, would be to select 1 or 2 outcome measures that you're going to consistently use all the time. I think we've made some progress with that, actually, because, frankly, Medicare's required us to do more outcome reporting. But I think that would be something that at an individual level or at a group level, to just say we're going to collect 1 or 2 things on our whole set of patients so that we can look not only at the individual patient but the group outcomes as well. I think the other thing that, and Ken, you mentioned this with vital signs with your facility, we have documented in our literature that as physical therapists, we don't necessarily do a grand job of monitoring vital signs. Again, I think we're making progress, and probably in home care, it's one of our practice settings in which we're much better at it than we are in others. But if you're in a different practice setting and you are not routinely checking vital signs on your patients, I think that would be an easy first step and a really important one from a patient safety. And when you think about it, it's just like that'd be one thing that you could do that everyone in your place would be doing consistently. And we know from the literature that if we do things more systematically, our outcomes get better. So that would be something that I think could be fairly simple but really important to do. And then the third thing that I thought of was more in the area of intervention. And in the patients that I work with, they have mostly mobility problems, not as many pain problems, but more mobility problems. And when you look at that literature, when I think about some of the themes that emerge, it's that we probably are when we think about the challenges that we place before our patients, that we're frequently probably sub-therapeutic, if you will, that we really just don't ask our patients to really kind of push the envelope a little bit as to the degree that they really could. We let them rest a little more than they probably need in some situations, and we don't ask them to do things that are hard enough for them. And by that I mean, like, when I think about balance, we don't ask them to really do the really challenging things. So that would be something that I would think about doing, would be thinking about maybe use the Borg scale and just say to your patient, we're going to try to be in this hard range. Now, again, you want to monitor them so that they're safe from a cardiovascular and pulmonary perspective. I don't want to discount that, but to really think about, let's try to increase the challenge. So for the patients that I work with, I think that's something that we could kind of step up the game a little bit more. From a manager perspective, I think, you know, the evidence on knowledge translation really suggests that the more that the team is engaged with selecting the activities that you're going to guide change toward, the more engaged, you know, the better your outcome will be with them. So if you haven't already, I would try to lead a discussion with the team that you're working with, and you know, pick 3 areas of practice that, you know, collectively you think you can do better, and you can guide that. You know, if you think your team isn't sure, we'll give them some suggestions of, here's some things I've observed, you know, and maybe have them rank order and just start and say, okay, we're going to do this one thing, and set some targets and really lay out the specific process. It's going to take more than one meeting that says, hey, let's everybody start checking vital signs, for everybody to actually start checking vital signs. So really thinking through the step-by-step process that's going to take in order to get that change, whatever that change might be. And by that, I really think, you know, the things that I always kind of go back to is not only what it's going to take to make the change, but then how can I help hold the clinician accountable? So I always go back to it. And then after we kind of get down that path and we're headed there, I go back and I look at my job description. I'm like, does this job description really say that I'm going to get, from a behavior perspective, what I really want? And if it doesn't, I work with whomever I need to change it. Or I look at the performance appraisal and I'm like, have I really articulated clearly that on this document that I work with these clinicians every year on, what I'm expecting them? So I always want to close that loop with that accountability piece as well, so that after you make the change, you have this way to circle back and reflect back with clinicians how well they're doing on an individual basis.
Those are great suggestions from both of you. I think this is a good place to wrap up our discussion. And before we completely do so, I'd like to make a couple of notes about this upcoming APTA Combined Sections meeting, as both of our presenters are going to be participating. Patty will be co-presenting a session called Knowledge Translation, Developing Evidence-Based Clinicians in Home Care. And again, that's at the APTA's Combined Sections meeting. So Patty, we're really looking forward to that.
Thanks.
And Ken is going to be co-presenting, as he mentioned previously, a session called Patient Engagement, Optimal Outcomes. And he's also participating in a pre-conference course entitled Future Thinking, Using the International Classification of Functioning, Disability, and Health to Define and Defend Appropriate Care Provision. So that's a lot to look forward to, and you both have given us a wealth of information to think about. Thank you both again for participating. And with that, I'm going to turn it back to you, Michelle.
Thank you very much.
Thank you.
Thank you, Mary. Thanks to everyone for watching. We'd love to hear your feedback and comments on today's Hangout and any ideas you may have for future discussions. You can leave a comment on our blog at www.ptnow.org, or you can send us an email at ptnow@apta.org.